Uh, Good morning, good afternoon. Welcome to Medicine Grand Rounds. Today we have a guest from the University of Toronto, Dr. Hladunewich. Dr. Hladunewich is a guest lecturer for a named lecture, the Thurman Lectureship. Dr. Michelle Chanchal, the chair of renal, is going to discuss the context of the Thurman Lectureship, and then I'll introduce Dr. Hladunewich.
Thank you, David. Good afternoon, everyone, and welcome to Medicine Grand Rounds. As Dr. Schwartz mentioned, we have the honor of having Dr. Hladunewich as our Thurman Lectureship. The lectureship is possible thanks to our gift that was provided by Alexium to the Division of Renal Diseases and Hypertension under the leadership of Dr. Johnson. And the proceeds of this lectureship are used to support the visit of a yearly visiting professor in the field of glomerular disease. And this is an opportunity to thank Alexium for their generous gift and to provide us with a capacity to maintain our future educational missions. David?
Thanks, Michelle. So Dr. Hladunewich is a professor of medicine in nephrology at the University of Toronto. She's the chief of medicine at Sunnybrook Health Sciences Center, which is one of the three hospitals, academic hospitals at the University of Toronto. She received her bachelor's and her MD degree from the University of Alberta, and then went on to house staff training and served as a medical chief resident at the University of Toronto. She did her fellowship both in critical care medicine and in nephrology at Stanford, and then was recruited back to the University of Toronto to develop her career. She has developed a very interesting focus of her career, which she's going to talk more about during this presentation, which is glomerular disease in young women, especially those going through pregnancy. She's received numerous research and teaching awards, mostly focused on this particular topic, so I especially look forward to her comments. If you have questions or comments during Dr. Hladunewic's Medicine Grand Rounds, please put them in the Q&A box. We'll get to them during the lectureship, and then I'll get to ask all those questions at the end of Dr. Hladunewic's presentation. So welcome, Michelle. It's good to meet you, and I really look forward to your comments.
Great. Thank you so much, David, and the Division of Nephrology here at in Colorado. I was actually really looking forward to coming to Colorado. This was all planned well before COVID, and me and my husband picked it so strategically, thinking we would do some skiing in your beautiful state, but it didn't quite work out that way. So I'm talking to you today about preeclampsia, and because I'm a nephrologist, I'm not gonna just focus on the kidneys, because I realize we have a general internal medicine audience, but I will refer to the kidneys often because I do think the kidneys are about the most important thing when we're talking about preeclampsia. So I've deemed it the sort of the placental-renal syndrome, if you will, and I'll have you humor me as I sort of take you through some of the thoughts in particular as they relate to the kidneys. I do have an important disclosure in terms of Roche Diagnostics, so I will be discussing how we now diagnose preeclampsia in Canada, which is not so readily done in the US. We will review that in some detail today with one of our studies. So let me just get everything running here, and I presume you can all hear me. So I wanted just to start with this stage, just to set the stage. We're all talking about COVID right now, but maybe when we're done with COVID, we can remember some of the things that plagued us before COVID. And this is fairly recent data from the United States. This is your maternal mortality trends. And each year, about 700 women in the United States die as a result of pregnancy or a delivery complication. And we estimate that approximately 50% of these maternal deaths are in fact preventable. And I just draw your attention to where the US is with respect to maternal morbidity and mortality mortality relative to the other sort of developed countries. Canada's right here. I'm at sort of 7.3 compared to your 26.4. So while the US maternal mortality rate increased by 16.7%, global maternal mortality rates decreased during that same time by 44%. And you can see that there is, as would be expected in any country, not just the US, that there is some ethnic and diversity in bad maternal outcomes. But a good chunk of these bad maternal outcomes, of course, it's not all of it. There's hemorrhage, there's sepsis, there's all things to consider. But preeclampsia is a very, very important condition. Preeclampsia is common. It affects 5 to 10% of pregnancies. It's actually the incidence in recent years and decades has actually been going up, and not just any preeclampsia, but severe preeclampsia. And that's actually worth discussing because it's going to lead nicely into what happens over the long term to these young women. It's serious. 500,000 fetal and neonatal deaths worldwide occur due to preeclampsia, 70,000 maternal deaths as well. And for every death, we think there could be about 100 near misses of women that end up in the intensive care unit or become very ill. And what's most important, what I really want to drill home today, is it's not a disease that ends with delivery. And that's why it has such an important part in anybody's internal medicine practice. So these are today's objectives. We want to understand the epidemiology of placental disease. So to answer the question, which of the patients that you are caring for are most likely to be affected by preeclampsia? I would like to go over some aspects of the pathophysiology. You could have 10 individual 1-hour lectures about the pathophysiology of preeclampsia. It really is an overwhelming pathophysiology. I'm only going to touch on a portion of it as it relates to what I'm using in Canada in order to diagnose preeclampsia at the bedside. I'd like to spend some time understanding the long-term sequelae of this disease, not just for mom, but also for baby, because this is at the point where internists should now be taking over the care of these women. And we'll go over this in some detail. So just to remind you what preeclampsia is just when blood pressure is in excess of 140/90 after 20 weeks gestation in conjunction with proteinuria. It's worth noting that recently the ACOG took proteinuria out as an absolute requirement of preeclampsia, but I have to be honest, I've been doing this for a lot of years. I have never, ever been at a bedside where a woman had hypertension and renal failure and did not have proteinuria. And when I show you some of the pathophysiology, you'll see that proteinuria really is part of this syndrome. So this is what I'm referring to as the placental-renal syndrome. And this is adapted from one of the articles written by Georgina Piccoli, who does a lot of writing in preeclampsia in Italy. And really the kidney and the placenta are both highly specialized vascular organs. And what's really interesting is much of what happens in the placenta affects the kidney and vice versa. Things that are going on in the kidney put women at risk for this placental disease. So these two organ systems work very nicely in concert with each other. And we'll go over that in numerous times in today's discussion. So let's begin with the epidemiology of preeclampsia. And the question as I remind you that we're trying to answer here is, which of your patients do you really need to think about being at risk for placental disease? So here are the usual risk factors, and many of you have probably seen these risk factors before. They're not new. This is what puts women at risk for preeclampsia. They might have a family history of preeclampsia or intrauterine growth restriction. That might result in more preeclampsia in their families. Nulliparity, so the first pregnancy, for reasons we don't totally understand, but maybe it's how our immunology works. Multiple gestations, the more babies are in you, the more the stress on the placenta. So that puts you at risk for preeclampsia. Advancing maternal age, which unfortunately in developed countries is becoming more and more common. Many women are delaying childbearing. And the longer we delay childbearing, the more at risk we are for preeclampsia. And of course, even independent of age, is this notion that if you also need to do in vitro fertilization, that also is an independent risk factor for developing preeclampsia. But if we're a bunch of internists, what we really need to be caring about are what are the medical comorbidities that are putting our women at risk for placental disease. And the ones I'm going to touch on today include obesity, hypertension, diabetes, CKD, and one that you're probably not familiar with in my placental renal syndrome is a history of acute kidney injury. So of course, with these comorbidities, it's not uncommon that there also is racial predispositions to preeclampsia, with much higher rates among Blacks and Hispanics as opposed to whites and Asians. It could be that there's a racial predisposition, but it also could just be the constellation of comorbidities which put women at risk. So let's go through some of these comorbidities. This is a recently published 18-year observational cohort study, and it just goes to show you that as the BMI increases, the risk of preeclampsia goes up along with it, but it's not all forms of preeclampsia. It's actually late onset preeclampsia, and there is a difference, and you're going to see that as the slides progress, that there is sort of possibly two types of preeclampsia. They may be very distinct entities, or they may exist somewhere along a continuum. And we don't really fully understand that, but we often see in women with chronic kidney disease or women with obesity and metabolic syndrome that their blood pressure and a high blood pressure, hypertension, proteinuria comes on towards the end of pregnancy. And that's what you see in this study with obesity. One of the most important risk factors that is actually quite modifiable for preeclampsia is hypertension. And this is a really nicely done meta-analysis and systematic review by Kate Bramham, who it works in the UK. She took out the renal patients, she took out everybody, and she was just looking at patients with chronic hypertension as the only risk factor. And the risk factor for preeclampsia increased 7-fold. And of course, anytime you increase the risk for preeclampsia, you're going to increase the risk for preterm delivery and small babies. But independently, hypertension is a really significant risk factor for preeclampsia. Diabetes is another important risk factor for preeclampsia. This is a small study, but it's actually, I like this study because it's very illustrative, and it goes to show you that the more significant your end organ damage is, the more severe your diabetes has caused with respect to damage to your endothelium, the higher your risk of preeclampsia. So women that don't have any kidney disease have lower rates of preeclampsia, but if you have diabetic nephropathy, which also is indicative of your other organ systems likely having exposure to too much sugar over the years, you actually have a fairly remarkably high risk of developing preeclampsia in a pregnancy. And finally, we could get to chronic kidney disease, which is sort of my wheelhouse. So I spend my day in something called the Pre-Kid Clinic. And the Pre-Kid Clinic is a pregnancy counseling clinic where I work in conjunction with maternal fetal medicine. We talk a lot about the risks of preeclampsia. We counsel women before pregnancy, and then we watch them very carefully during pregnancy, and we work together to diagnose preeclampsia. I'm going to talk to you about in some detail about how we do that as a team. But one of the most important risk factors for preeclampsia is chronic kidney disease. Now, this is a study, again, it's a systematic review and meta-analysis, and there's a lot of these. You're going to see there's a lot of these in the pregnancy literature, just because many studies are very small. So people try to pull them all together in these larger experiences. But this one shows that the overall risk of women with chronic kidney disease is about 10-fold of the regular population. Again, preterm delivery is more common, small for gestational age babies is more common. But just like any of our chronic kidney disease studies, heterogeneity is really quite significant. And there's effect modifiers. Proteinuria makes it worse. The type of kidney disease, in this case, it was glomerular disease that made the higher likelihood of preeclampsia. So this is important data. Now, this is a study that we're completing in Toronto. We're lucky that we have something called the Institute, we used to call it ISIS, but we can't call it that anymore. So we now have to call it ICES, the Institute for Evaluative Science, Clinical and Evaluative Science. And we have actually all the administrative data for everything in Ontario. And then recently, they linked it to every lab value in all of Ontario. So now we're able to bring in all the creatinines, which we weren't previously able to do. So in this study that we're just completing, it's 1.4 million pregnancies in our mom-baby database. We have available serum creatinine within 2 years in about 460 of them. And we're able then to determine the stage of CKD that they went into pregnancy with. And what you can see is this sort of nice relationship again, where if you have preserved GFR overall, you don't have a significantly increased risk of preeclampsia. As a matter of fact, it's very much like what we call the general population. As your GFR drops to 60 to 90, it goes up a little bit. As your GFR drops to 45 to less than 60, it actually goes up much more significantly. And below 45, it's really quite a significant risk of preeclampsia that women with CKD. We're currently cleaning all the proteinuria data. We won't ever have hypertension data in this big registry, but we will be able to fine tune this a little bit. Now, as I already mentioned, when you have preeclampsia, what's going to go along with it is preterm delivery. So here again are these same cutoffs for GFR, 90, 60 to 90, 45 to 60, and less than 45. And here you see very preterm delivery with it going up quite markedly, all the way up to 20% in women with higher grades of CKD. Here you have preterm delivery less than 37 weeks going up, low birth weight, and of course these babies therefore then spend more time in the NICU. So this is actually something that I think many of you know already, like you knew this, that, obesity, diabetes, hypertension, these are all sort of well-defined risk factors for the development of placental disease. But I'm thinking this is something that many of you have not heard about, and it's actually an important risk factor for future preeclampsia. This is a young woman from Boston, Jessica Tanger, and she works at the Mass General. And during her fellowship, she was able to get a data set whereby from essentially the clinics around the Mass General, where they had really good laboratory data, and they were able to see episodes of AKI. So she looked at episodes of AKI, which were, by the way, recovered. They didn't have kidney disease and then went on to get a pregnancy. These were recovered episodes of isolated AKI. And what she actually showed is that these isolated recovered episodes put women at increased risk for preeclampsia and preterm delivery. We actually had to look at it a number of ways in this study. So here's the odds ratios. Again, here's preeclampsia, preterm delivery less than 37, small for gestational age. But in order to get this paper published, they wanted us to actually also do a matching. So we matched 2-for-1 for age, race, BMI, diastolic blood pressure, and diabetes status, just to make sure AKI was not just a marker of these other disease entities. And in fact, AKI itself still came out as a significant risk factor for future preeclampsia, preterm delivery, and small for gestational age babies. She then got a slightly larger data set, and she was actually able to look at AKI by stage. So this is, these are well established in the nephrology literature, stage 1, 2, and 3. It's just the severity or how high your creatinine goes up. And again, let me remind you, this is all recovered AKI. So the creatinine went up and it came down. And when they were pregnant, they went in with what appeared to be normal kidney function. And you could see this dose effect that as you went up in the stages of AKI, the risk for preeclampsia went up further. So did preterm delivery, and so did small for gestational age babies. And then when you looked at it just in terms of sort of like a survival analysis, almost, they when did the risk start to get back to normal? Overall, it took about 18 months to start to see that risk start coming back towards the baseline. So that's actually really important data that many of us have now started to use within our counseling. So what does this mean for somebody practicing at the bedside? Well, in order to decrease the likelihood of a bad episode of preeclampsia, the women in our care do need pre-pregnancy sort of counseling and management. All young women should be sort of encouraged to try to maintain a normal weight. If they're overweight and they're not having a baby tomorrow, you might want to try a period of weight loss. Blood pressure really should be meticulously controlled, as should diabetes pre-pregnancy. Managing CKD was the topic of my first lecture today, and it takes a lot of work to lower proteinuria, make sure they're on safe blood pressure pills, make sure they're on safe immunosuppression, and we should always be preventing AKI. And by the way, the etiologies of this AKI in this study were variable. Some women had pylos, some women used non-steroidals, some was a post-surgery. But again, we always want to do our best to prevent AKI. If we can't prevent it, we should at least realize that it is a risk, and that women who've had a recent bout of AKI maybe can wait a little bit longer. I'll give you sort of a real life example. This week I had a young woman, she was post-kidney paint transplantation. Her kidney transplant was actually 2 years prior, and it went beautifully. And 6 months before she came to counseling to me, she actually had her pancreas transplant. And right around the time of her pancreas transplant, she had a really bad hypotensive episode. She doubled her creatinine, and she had a really significant episode of AKI. She's now recovered right back to baseline, but we had a long talk about timing of that pregnancy. We've elected to wait another 6 months just to give her a better chance. She's already going to be very high risk for a pregnancy, so we want to make sure she's had a good opportunity to recover from that AKI. So this data can be used very practically in your counseling and your management of patients. So now let's talk a little bit about the pathophysiology of preeclampsia. And suffice it to say, you could give 10 one-hour lectures on pathophysiology. So we're not going to be clearly covering all of the pathophysiology of preeclampsia. I kind of just want to share with you what I think is a really beautiful story in science, because I think it's really what really got us re-interested, re-engaged in preeclampsia. We finally understood it at the level of the kidneys. And once we understood that, then the science was really able to sort of take off. So let's talk a little bit about this pathophysiology. So I often say to the nephrologists in the audience, this is not a kidney, just so that they know this is a placenta. And the first thing that you really do need to learn about preeclampsia is that preeclampsia is at its core, it's a placental disease. It's not a renal disease. It's not a hypertensive disease. It starts in the placenta. And this is what's supposed to happen in a healthy placenta. The trophoblastic cells are supposed to embed very, very deeply from the decidual layer into the myometrial layer. So they set up these spiral arteries with a nice low resistance and really provide a healthy placental flow to the baby. But what happens in women who develop preeclampsia is they get the spiral arteries lack depth and they lack vascularity, and they actually become ischemic. So this is actually what you're seeing. So I already talked to you about what all those pre-existing risk factors were for shallow placentation. But once you now get reduced sort of placental perfusion, you start to release factors into your system that really cause the endothelial dysfunction that you see as part of preeclampsia. And it's these factors that I want to talk to you about today, because they actually may serve as diagnostic and future sort of treatment opportunities. And it's also why preeclampsia doesn't often happen in the first trimester. It's because you need the baby to sort of outgrow the placental reserve. So it takes time, and it happens in the second half. But that also doesn't mean preeclampsia can't happen early in pregnancy, so long as the placenta is thick enough. And sometimes you see that, for example, with a trisomy or something, where you could see preeclampsia sort of at all stages of pregnancy. So this was really the experiment in preeclampsia that really changed the way we looked at the disease. And this was done by Ananth Karamunchi, who's, as you probably know, he's a very lovely nephrologist. He's currently at the Cedars-Sinai, but he did gene expression profiling of placental tissue, and he found alternate splicing of an FMS-like tyrosine kinase receptor that created a soluble FLT1 is what they call it. And when this soluble kinase receptor is sort of circulating around in a woman's vascular, it's actually sopping up placental growth factor, it's sopping up vascular endothelial growth factor, and they're no longer available to interact with their native receptors. And that results in endothelial dysfunction. He found a second factor while he was doing this called endoglin, and endoglin is highly expressed in endothelial cells and trophoblastic cells. It's involved in that early vascular remodeling. It regulates vascular tone via enos, and he did a similar expression and showed that endoglin was also very upregulated in these preeclamptic placentas, and a soluble form of endoglin was also around, and it was most pronounced in women who went on to develop the HELP syndrome. So it was probably part of the severity of the disease scope. And when you look at these factors about 48 hours postpartum, you see that they come back sort of down to baseline. So in a very interesting experiment, he took actually isolated human soluble endoglin and soluble SFLT1, and he put it in a rat model. And of course, you see all his various experiments, but I draw your attention just where he gave both soluble endoglin and soluble FLT1, and you can see that developed mean arterial pressure went up, significant proteinuria, platelets dropped, and AST went up. Now, I don't know what a normal platelet count or AST count is supposed to be in a rat model, but I can tell you that this looks like a human sort of what you would see in a human HELP syndrome / preeclampsia. So this was a really important piece of science that really led to much of what I'm going to go on to talk with you about now. So at the kidney, and this is just, and again, I promise not to get too deep into the kidneys, but when I said in the early part that I think it's very, very unlikely to ever have preeclampsia without proteinuria, this is sort of how this works at the level of the kidney. So for those of you that are not used to looking at biopsy tissue, these are podocytes, or the little finger-like processes that prevent sort of your protein from slipping out. This is the filtration slit frequency, this is the glomerular basement membrane, and this is the endothelial layer. And we know vascular endothelial growth factor, which is produced by the podocytes, interacts with these high affinity kinase receptors, which sit on the endothelium. And they're really important to maintaining the integrity of our glomerular sort of filtration units. And this was a study that was done by Sue Quagan, where she actually took mouse models and she made one homozygous for knocking out podocyte-specific VEGF, meaning the podocytes did not sort of make VEGF. And in the homozygous model, it was not really compatible with life. But in the heterozygous model, it resulted in endotheliosis, loss of fenestration, or the space between those foot processes, and eventually loss of the podocyte. So the podocyte layers actually eventually fell out. Now, this is actually a human biopsy study that was done in 1998 when me and El Keshjani, for those of you who know him, who also works in Colorado, we were fellows, and that's dating us, so we're really old now. But when we were around Stanford, Brian Myers was actually biopsying women with preeclampsia and looking carefully at their tissue. And I think this would be a very challenging study to do now, because it's not quite ethical to biopsy women with high-grade blood pressure and lots of proteinuria, but irrespective, at the time it was done. And very much like Sue Quagan's sort of rat model, you see these swollen endothelial cells, subendothelial deposits, mesangial cell interposition. And normally this is sort of where our podocytes would be, and you can see that they're starting to efface and they're sort of coming off. And that's really the hallmark lesion of preeclampsia in the kidney. So these anti-angiogenic factors are really important with respect to acting as potential biomarkers. Though this is a study that was published again a number of years ago, and they have always in there, you're comparing controls to women who develop preeclampsia, and you can see that soluble FLT1 starts to increase a number of weeks before you even get full-blown preeclampsia. And what's actually interesting is that it kind of increases in every pregnancy. So even a healthy pregnancy, the placenta towards the end of that pregnancy does sort of start to degrade, and soluble FLT is starting to be released. And I think that might explain at times why we do see sometimes late onset preeclampsia in some of our women with metabolic syndrome, in some of our women with chronic kidney disease. Soluble endocrine goes up even sooner. And if you use them in conjunction, sort of a high soluble FLT to placental growth factor ratio and high soluble endoglin, well, that now becomes the makings of a potential biomarker for the diagnosis of preeclampsia. And that's actually exactly what they did. So this is more work from Ananth Karamunchi. And what he was really trying to identify was, what is that marker? What is that level of soluble FLT to placental growth factor wherein you start to see bad outcomes in pregnancy? And he really sort of narrowed it down to a ratio of about 85. And then there was a further study that happened after that called the prognosis study. And this again was a large study that was published a number of years ago now, just in the New England Journal of Medicine. They did a developmental cohort and a validation cohort. It was done in Canada. We were part of it, and it was done in parts of Latin America. And they took women who they felt were likely to have preeclampsia, anywhere sort of between 24 and 36. In other words, there was a clinical suspicion for preeclampsia, and they looked at the value of this ratio. What they actually found is it had a very good rule out value, that if this ratio was less than soluble FLT1 to placental growth factor ratio was less than 38, well, the negative predictive value for preeclampsia was 99.3%. Now, others have looked at it in different diseased populations. We know that a low placental growth factor is predictive of delivery within 14 days in both women with hypertension and chronic kidney disease. And we have been using it in a variety of studies and now clinically to diagnose preeclampsia from chronic kidney disease. So this ratio is something that's become extremely useful. It's not approved for use in the US, but this is now being used fairly extensively outside the US. So it's available in the UK, and they were using it well before we were. But now we've had this ratio now up and running in our lab, in our clinical lab. So I order this in my EMR, and it comes back within a couple hours, usually about an hour. And it's really, really helpful for clinically diagnosing, ruling in and ruling out preeclampsia. And this is sort of a little nomogram I found on the Roche website, but it does work with respect to how we're using it at my hospital at Sunnybrook. And I could give you a couple of just really nice examples of how it's been used clinically by my team. So not long ago, we had one of our patients on dialysis. We do have a number at any given time. We have one pregnant dialysis patient. Women on dialysis have a lot of fluid fluctuations. It's hard to tell. Her blood pressure was up. We really couldn't tell if maybe we just weren't taking off enough ultrafiltration. We sent the ratio. The ratio was actually negligible. It was 3. We adjusted her ultrafiltration. She continued on in the pregnancy. At that point, she was about 34 weeks. She delivered at 37 weeks, completely unremarkable, did great. Similarly, we had a young woman who was chronically hypertension. Her blood pressure was highly fluctuant throughout the pregnancy. She came into clinic. Her blood pressure was higher than usual. But honestly, it may not have twigged us simply because her blood pressure did fluctuate a lot. She was at 28 weeks gestation. We sent the soluble FLT ratio, and it was well over 85. It was actually in the 200s. Within about 24 hours, she progressed rapidly to the HELP syndrome, but we admitted her right out of clinic. It's also still helpful in the middle range, because we may have a woman that's in that middle range, and if she's before 34 weeks, we will give her the steroids to start for fetal lung maturation. So this is actually proven to be a really, really helpful tool. But we've only had it for a year. So you might ask, how did we diagnose preeclampsia in a CKD clinic before that? And this is what we did. So preeclampsia is absolutely a disease of the placenta. So you could always, if you don't have these nice fancy biomarkers, you could still look to the placenta. So in the first trimester screen, which is part of how we look for genetic abnormalities, Down syndrome, and so forth, one of the hormones that we look at is PAP-A. PAP-A activates insulin-like growth factors to facilitate placental growth. So in many women that are destined to sort of develop preeclampsia, they'll have a notably low PAP-A. We do placental morphology in our clinic. We look at it, and the obstetrician will sometimes come out and say, this is not a good looking placenta. It's bulky. They may comment on ischemic areas. They may comment on sort of, lack of perfusion. And these are things that they'll tell us. And then we know we're not dealing with a healthy placenta. Between about 18 and 22 weeks, we do uterine artery Dopplers, and we'll look for notching or an increased pulsatility index. And an increased pulsatility in excess of 1.45 means you have a high resistance in the placenta. So again, we're now bringing this woman into clinic more frequently so that we can watch her carefully. And then later in the pregnancy, usually closer to viability, we'll look at umbilical artery Dopplers. And of course, if they have absent end diastolic flow, we're admitting them. If they have reverse end diastolic flow, well, they're being delivered right away, because that's been associated with stillbirth. Now, we looked at this in our renal population because we wanted to know how useful it was, because not everybody does these fancy placental studies all over the place. But we did find that in our renal population, we actually just looked back to our last 150 patients with kidney disease, and we were able, the bilateral notching, the high placental indices, the low volume placenta were all quite predictive of preeclampsia. They were even more predictive of preterm preeclampsia, and they were predictive of having a low birth weight or a low birth weight centile in the baby. So they were very useful markers. But I do consult all over the world, and people are always, I get the same email. I have a woman, she's got protein, she's got some renal insufficiency. Does she have preeclampsia? And of course, I can't answer that question with that very cryptic information. But at the very least, what people can usually tell me is, how is the baby growing? So if a baby that's been, growing lovely along the 50th centile all of a sudden starts to really fall off the growth curve as the gestational age is progressing, you should be thinking that you're not dealing with the healthiest placenta, and in fact, be prepared that this woman may be evolving to develop preeclampsia. So how do we prevent preeclampsia and treat and manage it? And this is just going to take a few moments, but I just want to make sure that everybody is aware that if you're managing an internal medicine population, meaning you're dealing with women, advanced maternal age, obesity, hypertension, diabetes, CKD, and now a history of AKI, we are treating these women with aspirin. And also we're ensuring sort of an adequate calcium intake, but that's not as robust in terms of data. So aspirin given before 16 weeks gestation reduces preterm, but not necessarily term preeclampsia, which, as you're going to see when we go to the long-term outcome of preeclampsia, this is actually the one that we really do want to prevent. So this is one of many, there's actually quite a number. There's many meta-analysis. The original aspirin studies were not successful the big RCTs in the prevention of preeclampsia. And that's largely because they put it on in everybody, but now they're more aware of what the risk factors are for preeclampsia. So some of these meta-analysis that now look at just high-risk women are actually showing that there's a benefit in the prevention of preterm preeclampsia. But there is now a very nice RCT that sort of has solidified this. So I think it's really is part of just standard of care now all over the world. This was a study with women were given 150 milligrams of aspirin versus placebo. They started between 11 and 14 weeks, and they were dosed until 36 weeks. You got into the clinic if you had a constellation of maternal risk factors, a urinary arterial pulsatility index, like I've already showed you, a high blood pressure, PAP-A or placental growth factor. So they looked particularly for high-risk women. And in this constellation of high-risk women, it had a very, very robust preventative effect. So now we use this in all the women I see are placed on. In Canada, we only have 81 milligrams. So we have to put them on 2. And that's how we treat all of our women. In terms of calcium, it's just notable that some women have a very poor calcium intake in their diet. And there has been, this is a Cochrane review, the data is not nearly as robust, but there is some suggestion that if you're calcium deficient, it may put you at a higher risk for preeclampsia. So we do spend some time on nutrition with our women as well, just make sure they're eating adequately and appropriately for pregnancy, they're getting in adequate calcium intake. So, and all we really can do is prevent preeclampsia, because to this day, we don't have any treatments for preeclampsia. So a woman that is very sick with preeclampsia, all we can do now is delivery. That's really all that we have. But I think there are some really interesting sort of angiogenic factor inspired studies. Most of them are in animal models right now, but there is some already in human experimentation. So things that you could think about is maybe you want to give back placental growth factor, or maybe you want to get rid of soluble FLT1. So these are two things that are being considered in terms of the management of preeclampsia. A number of years ago already, Ravi Tadani and Nath Karamanchi used a lipid absorption column, and they sopped up sort of soluble FLT1 from women with preeclampsia. And you could see that they brought the levels down, albeit just transiently. As soon as you stop pheresis, it kind of goes back up. But at least in this small pilot study, they did show that they prolonged gestation. But one thing that I found that was very striking is just because you prolong gestation doesn't necessarily mean the pregnancy is healthier. The babies were still small because the placenta is still sick. So the best thing that maybe can come of some of these studies is that you get more time for steroids to work for lung maturation, buy babies through some very critical periods. But I think if we really want to make a difference in preeclampsia, we need to make our women healthier, and we need to improve implantation. So let's move now sort of to the other end of the spectrum, is what happens now after preeclampsia. What does this mean for a lifetime for mom, and what does it mean for baby? And I think this is something that is really critical for an internal medicine audience to understand, because you'll find that maternal fetal medicine often discharges women very commonly right around that 6-week mark, sometimes up to 12 weeks postpartum, and then their care can be pretty fragmented. So it becomes really important to think about what are going to be the long-term consequences now of having had this very complicated pregnancy. So let's talk a little bit about that. So essentially what you can kind of think about in a woman who has survived preeclampsia, and I'm going to share with you a little bit of which women are the ones that you really need to worry about, but it's almost like they become a vasculopath. So they have higher incidence of peripheral vascular disease, coronary artery disease, stroke, hypertension, end-stage kidney disease. And now preterm babies, like we didn't spend as much time years ago, studying preterm babies, but now we're doing really well with NICU care. And we actually have some very preterm babies surviving. Some of my kidney patients have babies, born at 25 weeks, 26 weeks, and their babies do survive. So we need to now start to really understand what's going to be happening to these children. And I won't spend much time on it because I'm not a pediatrician, but more just food for thought. So we never really know. I already shared with you what puts you at risk for preeclampsia. So if you really think about it, if the same things put you at risk for preeclampsia, maybe they're just the same things that are putting you at risk for future vascular disease. And maybe it's not really two different processes. And really, what did come first? It really is very much a chicken or an egg. Did you just fail a stress test? Did you have a pregnancy and fail a stress test, but you were always programmed to develop coronary artery disease later in life? It's something that we've spent sort of a lot of time trying to understand in our literature. So this was most of the really important epidemiological studies do come from Norway, where they have really beautiful population-based databases. And this comes from something called the Hunt Registry, which it uses medical birth registry. And they tried to answer just very specifically that question. Were you just at risk did the same risk factors that put you at risk for preeclampsia just later put you at risk for cardiovascular disease? And they found that for large part, some of it did. It is just the same risk factor profile, but not all of it. So BMI, 65% of the risk was attenuated. When you accounted for blood pressure, 50%, cholesterol, 40%, triglycerides. So there still was some likelihood that there was some damage caused to your vessels by the preeclampsia. So let's talk then what you should be expecting in the life of a woman who has survived preeclampsia. This is one of many meta-analysis on hypertension and overall the relative risk. This is the one that had nice long follow-up 14 years later. You had at least a 4-fold risk of future developing hypertension after your episode of preeclampsia. But you don't have to wait many years to start to see these curves emerge. This is actually a 12-month postpartum cohort, and it's 2 cohorts, 2 distinct pregnancy cohorts, compared to one of the control groups. And you can see about twice as many women have blood pressures that are either over 130 over 80 or medicated over 140 over 90 or medicated. So you start to see even early postpartum that women are developing hypertension. And this is a recent meta-analysis. It was actually just published just recently, just came out in the British Journal of Obstetrics and Gynecology. So it brings in more recent studies in hypertension and preeclampsia. And you can see it's the same pattern. It's about a sort of a 5-fold risk, but you could see that 18-fold risk in the first 6 months. And that kind of makes sense because you're actually healing from that endothelial insult. So women are often hypertensive in the first 6 months. It's about 4 times by 6 to 12 months and 7 times between 1 and 2 years. So they presented an algorithm, just for follow-up, where essentially this is kind of where maternal fetal medicine tends to stop following. So this is really where I think we as internists, as nephrologists, cardiologists, endocrinologists, really need to take over the care. And if women still have blood pressure in that early postpartum, we need to be really aggressive with lifestyle changes. But in fact, we should do that with any woman, even if she still doesn't have hypertension in those first couple of years postpartum, but she should have yearly blood pressure monitoring. And it's really quite shocking how many women, right after they have that baby, they fall out of long-term care. They get busy with their children and they just don't come back. And you're really missing an opportunity to treat them. This is another hypertension study, but I'm showing it to you for a very particular reason, because I'm going to start to show you a theme that emerges in all these studies over and over again, be it hypertension, be it stroke, be it coronary artery disease, be it end-stage renal disease. The more severe the bout of preeclampsia was during the pregnancy, the higher the risk for future disease. So here in this one, they looked at preterm delivery. And again, they have very big databases. They're able to really correct for everything from socioeconomic status to ethnicity, other comorbidities. These are really nicely done studies. And you could see preterm delivery significantly increases the risk, including in women who had normal body mass index. So again, showing you that there is differences in the type of preeclampsia that you had during pregnancy. So let's look at cardiovascular disease. It doesn't really take rocket science to take you from hypertension to cardiovascular disease. Certainly, if you have hypertension, you're likely going to also get cardiovascular disease. This was the first published study that made anybody think preeclampsia meant anything beyond birth of the baby. Because most of us that were doing research in the field were really studying the pregnancy. And then this came out in the British Medical Journal a couple decades ago, where they showed that preeclampsia itself did not increase your risk of death. But if you had preeclampsia and preterm delivery, in this case defined by before 37 weeks, you had this almost threefold risk of death compared to women with a normal pregnancy. And if you looked at just cardiovascular death, it went up eightfold. So this was really, really very important data. So this is one of my favorite studies, not because it's done by one of my good friends in Ontario, but because it actually really speaks very importantly to how much data we need to gather about that pregnancy. In other words, I'm going to tell you at the end, it's not enough just to say, oh, did you have preeclampsia? And then use that as your ability to risk stratify a woman. This went on, we studied maternal placental syndrome. This was in essentially 1 million women in the Ontario databases. 75,000 of them had preeclampsia or some form of placental syndrome. They were able to show the increased risk for cardiovascular disease, coronary artery disease, cerebral vascular disease, and peripheral vascular disease. So they went beyond the usual cardiovascular studies to look at other vascular systems. But what's really interesting here is these are the survival curves depending on what type of a pregnancy complication you had. So here's an unaffected pregnancy. This is a woman who had preeclampsia. This is a woman who had preeclampsia, but also had poor fetal growth. And this is a woman who had preeclampsia that was so severe she had fetal death or she had a stillbirth. And you can see that the more severe the placental disease, the bigger the impact it has on mom's future health. This was shown as well in another study, a cardiovascular disease study, where they looked specifically at stillbirth. So in other words, your placental disease is severe enough to cause a stillbirth. And again, you saw this increased risk of myocardial infarction, future cerebral infarction, and renal vascular hypertension. So what type of preeclampsia you had in pregnancy absolutely matters. This is a really critical study. This was done by the Child Health and Development Studies cohort. This was a large study, and it really tells us when we should start to be watching these women. So here again, you have early onset preeclampsia, and you could see that decreased survival curve in women who had preeclampsia before 34 weeks gestation, whereas if you had it later, you're not that different than the normal unaffected population. They had 30 years of follow-up, and the median age when women started to have events was 56. So that's a really young age to be having cardiovascular disease for a woman. It also matters if you had preeclampsia in more than one pregnancy. So if you had 2 affected pregnancy, your all-cause mortality goes up 2-fold, ischemic heart disease goes up 3-fold, stroke goes up 5-fold, and diabetes goes up 4-fold. And these women died on average 5-6 years earlier. So the kidneys are always a little bit more complex. So, like I said you at the beginning, I think about this very much in terms of a placental-renal syndrome. There's many things that predispose you to chronic kidney disease, preeclampsia. There's many things that predispose. So maybe it's all just the same things happening that are predisposing you to both. But I actually don't believe so. I do think a part of the preeclamptic episode that a woman has damages her kidneys for the future. This is a really nice work that's been done by Vesna Garovic at Mayo Clinic. She does actually really wonderful work looking at podocytes in the urine. And this is a study where she was looking at podocytes in the urine in women during a bout of preeclampsia. And what she found was the number of podocytes that she found in the urine was directly sort of correlated with the amount of proteinuria. So again, the more severe the episode of preeclampsia, the more of these cells that were found in her urine, these podocytes, these very important portions of our filtration barrier in kidney disease. Now, I've thought about this many times, and the reason why I spend a lot of time thinking about Vesna's work is when I'm on the wards and I'm managing these women clinically, we do a lot of expectant management. So we try to pull these babies far out as long as we can, not just at the first sign of preeclampsia, but we manage blood pressure. All of Dr. Tadani's studies are also, they're also, designed to prolong the pregnancy, which means we have mothers that are sort of swimming in these angiogenic factors, sometimes for weeks because we don't deliver them. And I've sort of yet to see a good study where somebody correlates the duration of expectant management with the outcome of future kidney outcome. But suffice it to say, end-stage kidney disease is more common in women with preeclampsia. This again is data from Norway, and they show a significant increase in the risk of preeclampsia, and it's a dose dependent. So if you have 2 affected preeclamptic pregnancies, your risk is higher. If you had 3 preeclamptic pregnancies, once again, your risk is higher. They once again show you that if you had early onset preeclampsia, or in this case, a very low birth weight baby, evidence of a sicker placenta, you had a higher risk again to go on to develop end-stage kidney disease. The absolute numbers are still small, so it's sort of hard to tell a woman what her likelihood of getting it. So you have to always remember that the absolute numbers are small, and the etiologies are really variable. But again, I'm always thinking back to that expectant management of preeclampsia. When we look at these studies, the majority of the women were glomerulonephritis. So it makes you wonder if you've already lost a significant number of podocytes, and then you happen to also develop over time FSGS or IgA, might you have a worse renal outcome? This is not just coming from Norway. This is a Taiwanese study, 28,000 women. The hazard ratio for developing CKD was 4.37. Increased risk of ESRD, 2.72. They again adjusted it very well. And it mattered if you had preeclampsia versus gestational hypertension. The more severe the disease, the more likely you were to go on to get end-stage kidney disease. Many people have tried to just decide, is it just the aggregate of risk? This is sort of a nice family study where they just looked at women again in Norway. They had either affected or unaffected family members just to see if they had a congregated risk for developing chronic kidney disease. And they didn't feel that they did. And in fact, we do think preeclampsia per se causes some renal damage. And this we haven't published yet. This is brand new. I take you back to where I showed you AKI puts you at risk for placental disease. Well, placental disease also puts you at risk for AKI. And this is some of our early data out of our same large Ontario database that actually is showing it that if you had preeclampsia, you recovered from your preeclampsia, you're more predisposed to sort of these episodes of AKI, which we ascertain from administrative data codes. So again, it takes us full circle. So there's lots of sort of underlying theories to this potential placental-renal syndrome. Altered hemodynamics of pregnancy, fluid shifts, and so forth. Are we giving them endothelial damage, and then from there they get microbinuria, and then they go on to develop other kidney diseases? The podocyte loss to me, I think, is really interesting. And do we then develop glomerulosclerosis because we've had loss of podocytes, and therefore are we losing renal mass? And we know that the angiogenic factors, I didn't go into this in detail, but they also factor well into the renin-angiotensin system, and that may be part of what aggravates our predisposition to cardiac disease, vascular disease, and chronic kidney disease. So before I became an administrator, I used to do physiology, and this was sort of a study that we did many years ago, but we used flow-mediated dilatation. And what was very unique about this study is we had really nicely phenotypically described populations. So because I was working in a placental clinic with my MFMs, they could find me late onset preeclampsia, early onset, which in our case was before 34 weeks gestation. And then they also found me a group of normotensive women who didn't have preeclampsia during pregnancy, but had IUGR. And this is a real subgroup that nobody understands completely. But here's their flow-mediated dilatation. Controls in late onset preeclampsia were not that different, but they were remarkably different than early onset preeclampsia. And IUGR, which would be indicative of placental disease, was even worse. And what was really interesting is we had from their pregnancy, remember this is 1 year postpartum, but in their pregnancy, I had all their placental Doppler examinations, and there was a correlation that the sicker their placental flow was, the worse their FMD was a year later. We also looked at the renin-angiotensin system. We gave them angiotensin infusions. Again, this is 1 year postpartum, and we had controls. We had early onset preeclampsia, we had healthy gravid controls, and we had never pregnant controls. And you can see that they were more sensitive to angiotensin. This is their mean arterial pressure. This is their diastolic. We used a contraption called lower body negative pressure. For those of you who've never seen it, just consider yourself lucky. It's really kind of something out of a chamber. We put them in a chamber, we suck all the blood into their ankles, that stimulates your renin-angiotensin system, and then we watch to see if you pass out. So I only did one study like that, but we did find again that the women with preeclampsia withstood this stress. They had more upregulated renin-angiotensin systems. They withstood the stress way more than women with healthy pregnancies. So the cardiologists got it. They did get it earlier, I think, than the nephrologist. So if you look at sort of in 2011, they already started to say you must ask about the history of preeclampsia, gestational hypertension, and pregnancy induced as part of your vascular stratification. And in terms of nephrologists, this is a recent cross survey that we did. It was just published just last year. This was all American and Canadian nephrologists, largely from Academic Health Sciences Center. So, basically pretty much they would know, a lot about preeclampsia. And although we do not a bad job, most people will do a bit of a history with women. How many pregnancies have you had? Did you have any miscarriages or termination? Did you have gestational hypertension? They'll ask about preeclampsia as well, but very few actually asked what I call the money questions. And if you were going to narrow down to the 2 questions to ask women to really stratify their future vascular risk, ask them what the gestational age of their offspring was, and most women will remember, and ask them the size of their children. So women that had early onset preeclampsia, they say, oh, I delivered at 27 weeks and my baby weighed 4 pounds. You have to realize that this is a woman that is going to have future vascular risk. So these are the ones we don't ask them very often, but this should be part of everybody's history and physical in a woman. So the recommendations are fairly common sense. Women with early severe disease and fetal growth restriction require regular vascular risk assessments. Most recently, one of my young fellows has taken this on in Toronto. She's developed sort of a postpartum clinic. It's a hypertensive cardiology clinic, and she continues to follow these women now yearly for many years, and she does a very aggressive job of modifying their vascular risk. Placental disease should be ascertained in histories to assist with this vascular risk stratification. All women should be encouraged to adopt a healthy lifestyle before and after pregnancy because the risk factors before are the same as after. So all women should be tried to do diet, exercise, smoking cessation. And we've got to be looking for the women that need treatment. And, based on some of our studies that we've done in the renin-angiotensin system, this is a very good way to treat postpartum hypertension. They respond very nicely to RAS blockade, and you should treat hyperlipidemia when necessary per cardiology guidelines. Now, this is just for food for thought. What you have to remember is you don't just have mom, you also have baby. So when you have a mom who's sick, has bad preeclampsia, delivers early, you frequently have an intrauterine growth restricted baby who's been exposed to antenatal steroids and all kinds of antenatal medications, had a preterm delivery. Now they have other insults where they can have episodes of AKI, they get necrotizing enterocolitis, they get all kinds of insults. So they have a real vulnerability to renal insults and damage. And I don't think we really realized this till recently. Now we have these children that are surviving who were born at 25, 26, 27. So I've been practicing long enough now that I'm starting to now care for my patients' children. And these children, we know that the lower their body weight, their birth weight was, the lower their nephron mass, and that puts them at risk for hypertension, puts them at risk for FSGS. So for all the nephrologists in the audience, anybody that comes to you with focal segmental glomerulosclerosis, you also need to ask them when were they born? What was their birth rate? Because this is another important risk factor for these diseases. So my summary statements are as follows. Preeclampsia is a common severe disease in women with medical comorbidities. Understanding of the physiology is helping us with diagnosis, and it's probably going to lead to new treatment strategies. But I think the more important thing is to make our women healthier. Women who develop preeclampsia go on to have increased morbidity, mortality as sort of vasculopaths. Their children then go on to have chronic disease. So it's really important as practitioners that we target them and keep them healthy over the course of their lifespan. Thank you.
Thank you, Dr. Hladunewich. That was great. We have just a few minutes for questions, so I'm just going to focus on a few of the most important questions that came up. Tell us a little bit more about the risk factors for preeclampsia in terms of genetic risk factors and also race, ethnicity risk factors that are independent of the ones that you mentioned.
Yeah, so it's really hard to take take the risk factors and pull them out independently. But there certainly have been large studies that have, done it where you look at, there is likely independent genetic risk factors. There is without a doubt a whole literature on ethnicity and risk factors. The issue is a lot of it tends to be tied together. So people of certain ethnicities tend to also have more preponderance to diabetes, to hypertension. So it's often really challenging to disentangle all the risk factors. One of the things you'll see online now when you're sort of caring for pregnant women, they're all over the internet, and some of your patients may bring this to your attention, is there's a whole bunch of these little risk calculators online where, the women can they sit at Google, they put in their race, they put in some, state, their weight, their size, their comorbidities, and it gives them some, risk calculation. It's not the most precise, but it'll tell them if they're low, medium, or high. And it's hard to do it with precision just because these risk factors are so intermingled with each other.
So women who have had a pregnancy and unfortunately have had preeclampsia oftentimes present with another pregnancy or want to get pregnant again. How do you counsel them in relation not only to their risks, but the risks of their children?
Yeah, so it's counseling it's so challenging, right? Because everybody has such a deep desire to have children, and when you have one child, you often want two children, and so forth. So women that have sort of severe early onset preeclampsia are certainly at risk for having a second episode. So sometimes in between the pregnancies, we will really concentrate on mitigating some of those risk factors. Often if you really look hard and sort of say, was there anything that resulted in that first episode of preeclampsia? And often there was. Like, it's not uncommon she maybe didn't know she had hypertension. She wasn't managed with respect to her hypertension. So you can be doing modifying things between the pregnancies to make that second one more, more healthy. A lot of women in their first pregnancies, they didn't get aspirin, for example, because they didn't know they were at risk for preeclampsia. Now you make sure they're on aspirin, you make sure they have been multivitamin, you make sure they've had counseling. So having preeclampsia in your first pregnancy is not a guarantee by any stretch that you're also going to have it in your second pregnancy. We quote women, rates, from about 20% that you're still going to get at the second pregnancy, but it's not a guarantee. You often see a pattern as well that when you had a really severe bout of preeclampsia in your first pregnancy, that even if you get it in your second pregnancy, it tends to be later in the pregnancy, so often not as severe. But one of the things that you really want to be very cognizant about is how stressful that is for a young mother. Many women who had preeclampsia in their first pregnancy, now they've gone into a second pregnancy. It's a very high stress situation for them. I use a lot of peer support, and I actually use a lot of social work and nurse practitioner support to help these women. But again, think about what might have put them at risk and see if you can modify any of those risk factors, use preventative strategies, which she may not have had in her first pregnancy, and time them appropriately as well, because you should wait at least a year if you had a very bad bout of preeclampsia, because that's a significant insult to your kidneys in terms of AKI. So we also try to time the pregnancies with these women.
Lastly, tell us a little bit about apheresis in preeclampsia.
So when the apheresis that they were doing with Dr. Tadani's group is not just your regular apheresis. So regular apheresis has been done in preeclampsia. There were older studies of just a garden variety plex, and it really doesn't sort of make that much of a difference. There is some small studies that more case series that might suggest it helps in HELP syndrome. He used an absorption column that was meant to suck up the soluble FLT1. And with that, he showed that they were able to prolong the pregnancy. But one of the things that was very striking about their studies is the babies didn't grow. So just because the pregnancy was lasting longer, the baby wasn't growing along with that extra time. So it might still be very important because of lung maturation to get the steroids on board to buy that time. But I really think we need healthier populations and more public health types of approach to make pregnancies healthier than sort of these rescue therapies when they finally get really bad preeclampsia.
Well, this has been fantastic. Thank you so much for educating us about preeclampsia.
I presume there's somebody there. I only see a bunch of black squares, but I presume people joined us, so that's good.
There are a lot of people here.
And people are they're very welcome to email me and send me critiques. So I saw nothing. I just felt like I was talking to myself in like a loony bin.
You were talking to about 100 people.
Oh, okay, that's good to know.
And it was well received. There are lots of questions that are going to go unanswered because we've run out of time, but I want to thank you for visiting with us and educating us about.
Thank you for hosting me in my bedroom in Colorado. All right, take care. Bye-bye.